And as usual, I'd like to thank the healthcare workers who are serving as frontline fighters every day and working relentlessly to protect us and make the continent safe. And especially at these critical times as we move into vaccination of our people. I really personally would like to welcome Professor Salim Abdul Karim, who is a colleague for many, many years, a good friend, and we have been working closely since the start of this pandemic on the continent to find solutions, continue to adjust our strategies as we fight this incredible and unprecedented pandemic. Professor Karim also serves as the co-chair of the consortium for the clinical trials on COVID-19 in Africa with Professor Samba Sow from Mali. And I must say, they've been doing an incredible job in guiding that working group as we look for solutions on vaccines. I think I'm particularly honored that he's joined me today to really expand on the vaccination and vaccines that we are seeing or beginning to see and that they arrive on the continent. What an exciting moment, historic moment, but what a remarkable challenge that still remains ahead of us. As usual, before we get to the Professor Karim, let me give you a brief update of where we are with the pandemic, where Africa's CDC is with respect to supporting member states. And lastly, to give you an update on the overall, at a much higher level, panoramic view of where we are with vaccination on the continent. As of 9 a.m. East African time today, the African Union member states have reported the following: a total number of cases across 55 member states as of this morning stand at 3.9 million cases of COVID-19. And that represents 3.4% total cases globally. As usual, the recovery rate continues to be impressive. 89% of the individuals or people that have been infected have recovered. That is about 3.5 million total. In terms of deaths, we have recorded as a continent 104,000 deaths, and that represents a case fatality ratio of 2.7%. This is troubling because our case fatality ratio has increased or continues to increase compared to the global case fatality ratio, which stands at 2.2%. In terms of the number of countries that are in Africa that are reporting the highest caseloads, they include South Africa with 1.5 million cases, Morocco with 480,000 cases, Tunisia 235,000 cases, Egypt 184,000 cases, and Ethiopia 160,000 cases. There are, as we speak, 38% of our member states or 21 countries are reporting a case fatality ratio that is over 2.2%. Remember, the 2.2% is the global average, and we always use that as a benchmark. Let me now segue to the variants. 13 member states have reported the presence of the 501Y-V1 variant, in other words, the lineage B117. And these countries include Algeria, DRC, Gabon, Gambia, Ghana, Kenya, Libya, Morocco, Nigeria, Rwanda, Senegal, South Africa, and Tunisia. 11 member states have reported the presence of the 501Y-V2 variant, or the lineage B1351. They include Botswana, the Comoros, DRC, the Gambia, Ghana, Kenya, Malawi, Mozambique, Rwanda, South Africa, and Zambia. You recognize that, as I said last week, Africa CDC takes exception in attributing a variant to a country because we have not done that with the virus itself. So there's absolutely no rationale in attributing variants to countries where of origin. So we will continue to stick with the nomenclature. In terms of the trends that we have observed across the continent for the past 1 week, that is week 8, we have which spans between February 22nd and February 28th. If you compare that with week 7, last week, we have the following observations. First of all, we have recorded 68,000 new cases across the continent, and this represents a 9% decrease from the previous week when we met at the same time. The highest proportion of new cases are seen from Southern Africa, representing 35%. And by region, we also observed the following: North Africa, 25%, West Africa, 16%, East Africa, 18%, and Central Africa, 7%. The following 5 countries are reporting the highest number of new cases. South Africa, 9,500 cases, Ethiopia, 6,200 cases, Tunisia, 4,700 cases, Egypt, 4,200 cases, and Zambia, 4,000 cases. We now look at the deaths. A total of 2,300 new deaths were reported over the period of the last week, and this represents a 15% decrease from the previous week. Now, let's see the trends over the last 4 weeks. So if you look at the period between the 1st and 28th of February, we recognize that there have been an overall 15% average decrease in new cases across the continent over the last 4 weeks. And the trends by, the trend by region are as follows: 23% decrease in Southern Africa, 16% decrease in Western Africa, 11% decrease in Northern Africa. However, we are observing a 14% increase in Central Africa and a 7% increase in East Africa. If you plot the graph in East Africa, you take all the countries together, it will seem to suggest that we might as well be seeing the start of a third wave in Eastern Africa, if I take all the countries together and box them, but not disaggregating them by countries. So in terms of deaths over the last 4 weeks, again, we have observed an 18% average decrease in new deaths across the continent. And there is the breakdown of the deaths by the most populous countries include 25% decrease in South Africa, 18% decrease in DR Congo, 1% decrease in Egypt, however, a 37% increase in Ethiopia, an increase of 26% in Kenya, and 10% average increase in Nigeria. Let us now look at the testing. As a continent, as of 1st of March, 35 million cases of COVID-19 have been conducted across the continent with a positivity rate of 11.2%. Over 750,000 new tests were reported over the last week. This represents a slight decrease of 3% if you compare that to the previous week. Our team continues to mobilize in the spirit of the partnership to accelerate COVID testing to supply 19.2 million antigen tests across all member states. As we have discussed on this forum over and over, we believe that the antigen testing will be a game changer because of the simplicity to implement, the ability to conduct the test in more severely restricted areas in terms of geography and in terms of training people. The Africa CDC has continues to work with UNICEF to procure additional molecular testing, that is the so-called PCR testing. Over 300,000 of those tests will continue to be distributed. So we are not abandoning our major test, which is a molecular test. We are just supplementing that with other tests. In terms of other capacity, we now have trained through the Institute of Workforce Development over 11,000 clinicians and equipping them with the ability to the latest information on case management of patients across the continent. We have also, in the last week, begin training of healthcare workers on vaccination, and that will be in partnership with the HOPE, Project HOPE from the US and Brown University, where just last week we trained over 150 clinicians and AP managers in Ethiopia and South Africa. And such training will continue in the coming weeks, especially with the Francophone speaking African countries. Let me just conclude by expanding on the vaccine activities. As you've all heard last week, this week was like, I'll call it a tipping point in what we have been expecting, where many countries started receiving vaccines from the COVAX facility, and we are extremely appreciative of that. These include Nigeria, DRC, the Republic of Kenya, Cote d'Ivoire, Angola, Republic of Rwanda took delivery of their first COVAX vaccines. And this list is perhaps not exhaustive, because as we speak, there's an accelerated move to begin to distribute the first doses of the vaccines. What we plan to do next week is to have an extensive catalog of what exactly the number of doses that each country is receiving, so that we can discuss that more openly. But for this week, we have some numbers, but it's still premature to be putting out numbers there. As the vaccines are distributed, as we have discussed on this forum again, we have a simple formula that says vaccine plus vaccination equals life saves. So yes, we are having vaccines. We now have to focus on the vaccine delivery. And as such, Africa CDC, as you know, has launched what we call the African Vaccine Delivery Alliance, in abbreviation AVDA. And this is really similar to the consortium that Professor Karim is chairing, is co-chaired by our colleague, Dr. Yodi, based in Nigeria, and myself. And the whole purpose is really what we call a continent in the areas of setting up vaccine centers, in the areas of coaching delivery, in the areas of training at scale, and in the areas of logistics, overall logistics of supply chain management. So that is what that alliance is meant to do. And you heard last week when we announced that the European Union had committed 100 million euro to supporting us. And we are in the process of finalizing a work plan on how to use the 100 million euro to support this alliance, so that we can make sure that the vaccines, once they come in, they are rolled out. You get the finality is getting that needle into somebody's arm. And then we can tick the box, and we know that that person is protected, and not just protecting him or herself, but protecting their loved ones. Another, along the spirit of good news, you also heard last week that the United States Food and Drug Administration issued an emergency authorization use for the Johnson & Johnson vaccine, which is a single-dose vaccine. And the African Regulatory Task Force, which we are co-leading, will be reviewing the vaccine for its use on the continent as well. And we had earlier issued guidance on how these vaccines will be introduced on the continent. We will be hosting a 2 days conference, high-level conference, chaired by His Excellency Musa Faki Mohammed, the chairperson of the African Union Commission, President Cyril Ramaphosa in his capacity as champion for COVID, and His Excellency Felix Tshisekedi, who is the current chair of the African Union, on April 12, where we bring all stakeholders together to discuss a framework on vaccine manufacturing on the continent. We'll be looking at three things. One is, how do we support manufacturing on the continent so that by the end of the year or in 1 year's time, manufacturers begin to produce COVID vaccines? And that will be a comprehensive meeting with all stakeholders, not just within the continent, but outside of the continent, including donors as well. Secondly, will be to use the COVID pandemic and crisis to strengthen our overall manufacturing across the continent so that we do not get ourselves into this scenario where we scramble for vaccines on the continent. And thirdly, how do we establish centers or hubs of excellence across the continent so that it can get involved in research and development for vaccines? So colleagues, let me at this point conclude this, and I will let, we will go forward and do Professor Slim Karim so that we finish the COVID section, and then we'll do the Ebola briefing last so that there's some alliance with the COVID story. So over to you, Wayne.
You are very right there. It does make sense for us to finish one topic before we move on to the next. So now we invite Professor Salim Abdul Karim. I have already introduced him, and Dr. John has also said something about the great work that he's doing. So without much further ado, let me invite Professor Abdul Karim to address us. Prof, you have the floor.
Thank you very much, Wynn, and thank you very much, John. It's a great pleasure and an honor to be with you here this morning. I will be sharing my slides. I'm just checking if you can see my slide.
Yes, we can,
okay,
Prof. Yes.
Wonderful. So let me just start by acknowledging the good work of the African CDC. And I don't say so because of my good friend John Kengasong, but because I've been at the coalface and I've been able to personally witness the hard work and dedication that has really enabled us across the continent to respond appropriately to this pandemic. So what I want to do in the next 10 to 12 minutes is I'm going to tell you quickly about epidemic trends and about variants. And let me start off with, what's the situation in the world? Well, we all got a surprise that in the middle of January, on the 11th of January, the epidemic started declining at a global level. And we saw for the first time ever in this entire epidemic, almost a year to the day, that the epidemic showed a consistent decline from the 11th of January to the 18th of February. And over those 5 weeks, the epidemic at a global level declined by just over half. So that's quite a steep decline and a consistent decline. Unfortunately, it's sort of not staying that way. It's now trying to decide whether it wants to stay flat or go up. And we'll keep a very beady eye on that. And I'll talk about this decline because it's really a very significant decline, because we've seen declines before, but those have been declines for a week. But a 5-week decline in this way, well, the first is to recognize that the pandemic is a mosaic of country epidemics. And you can see that in the way in which the countries are colored differently in the slide on the right-hand side. And you can see that our continent has been much less affected compared to North, South America, or Europe or Asia. But you can see that at the far end of Southeast Asia, that those colors match much of what we see in Africa. So we have seen a global decline over 5 weeks. Well, when you look at that decline, you want to understand what are the drivers of that decline. Well, the drivers of that decline are principally the declines we have seen in the US and in Europe. And the reason why we're seeing those declines, I'll come to in a minute, but essentially countries in North America and in Europe are now completing their winter second waves. If you look at, how are we in Africa contributing to the global pandemic? Well, I have to say, thankfully, a very small contribution. If you look very carefully, you'll see Africa right at the bottom, above March 1st, 2021. So we make a very small contribution to the global pandemic, and we have a minimal impact on the global pandemic numbers and the global pandemic trajectory. And let's look at, so why are we seeing this decline? Well, if we look at Africa, we've contributed in a little way to that decline because we've seen our own decline, and that decline that we are seeing is being influenced by South Africa largely. And you've already heard the numbers, so I won't go through it. Professor Mkengasong has outlined very clearly where we are in the global pandemic. So let's go on to the 4 key reasons why COVID-19 cases decline so that we understand what we are observing in the global trajectory. So the first is that if you take the population, there's a subgroup, a small subgroup of people who are those who are most at risk. So those are the individuals who move around a lot. Those are individuals who may not be following the rules. Those are individuals in high-risk occupations. So those individuals who are most at risk, they tend to get infected quickly when the epidemic is increasing. And once they've been infected, they are now immune. Now, we haven't reached herd immunity. Herd immunity requires a much higher level, but we are saturating with the natural immunity those who are most at risk. And so they don't get infected again, so we start seeing the numbers decline. The second is, of course, the impact of government interventions, that when you reduce the movement of people and gatherings, you decrease viral transmission. That's very clearly seen in South Africa, that when you look at when the government imposed restrictions in December, exactly 10 days later, our epidemic starts to decline, as you would expect in relation to the incubation period. And so you see the impact after the incubation period. Then we see an increase in protective behaviors during the waves. That when we have the cases going up, people become aware, and the whole issue of cases, people who are sick, people who are dying, becomes personal. The issues become personal. Somebody in your family, somebody you work with, somebody you know well. And so what happens is that we see an increase in protective behaviors. So it's a combination of people getting the most at risk, becoming infected and immune. It's government interventions. It's about protective behaviors and people taking protection personally. And then finally, it's the cyclic nature of the waves. And we see that very clearly in South Africa. If you look at our first wave, which is sort of more like an African Mount Kilimanjaro number of cases, and you can see the hospital admissions in the gray bars. If you compare that to our second wave, which was driven by the 501YB2 variant, you can see how the cases rose much faster and to a much higher level, akin more to like a Mount Everest than a Mount Kilimanjaro. And you can see that it wasn't just that the cases rose, the number of hospitalizations rose dramatically. It put a huge amount of pressure on the healthcare system in South Africa. And as a result, deaths go up. So we have now recovered from the second wave. The cases have declined for the reasons I've just outlined. And we are now in a situation of low transmission. And the government has eased restrictions, and we are back to level 1, which is the lowest level of the restrictions that we have in place. So that's where we are in South Africa. I'm going to talk very briefly now about variants, because this picture that you see in our second wave is a picture of the impact of the 501YB2 variant. So what do we know? Well, globally, there are 3 variants of concern. The first is called the B117, and that was first described in the UK. It has lots of mutations, 23, but importantly has this one key mutation in the receptor binding domain, in that part of the virus that attaches to the human cell. Then you have the 501YB2 variant we described from South Africa in December. And there, the difference is that this variant has 3 mutations in that key part of the virus that attaches to the human cell. And then more recently, we've seen from Manaus in Brazil, the description of the P1 variant, which has more mutations and also has the same 3 key mutations in the receptor binding domain. So globally, we have these 3 variants of concern. The one I'm going to talk about is the one in the middle, the one that we know is present in South Africa and indeed is now occurring in other countries as well. So what do we know? Is it more transmissible? Is the virus spreading faster? Well, let's just look at one province in South Africa. If we look at the Western Cape and you look at its first wave in the light green line, you can get some idea of what the wave looked like. Compare that to the second wave, driven largely by the variant. You can see that the cases rose much faster, higher, and then from the peak declined quite rapidly as well. So if you compare the two, it took the Western Cape 50% faster to reach 100,000 cases in the second wave, 54 days, compared to the first wave, 107 days. Now, there are many caveats to just drawing a simple comparison, but it gives you some idea of what the difference is. Our colleagues from the London School of Tropical Medicine and Hygiene have done a modeling analysis, and they find similarly that the variant is 50% faster in the way in which it's transmitted. So the variant spreads faster. So what do we know about whether it escapes immunity? So this is a bit of a challenge because we want to know, can you get reinfected? If you were infected in South Africa's first wave with the previous variants of the virus, are you protected against this new variant? Well, just serendipitously, a vaccine trial that was being done in South Africa had 31% of its participants had past infection. And they measured the attack rate. And what they show is an attack rate of 3.9%. And it was the same whether you had past infection or you didn't have past infection. This is the first empiric evidence we have to show that past infection provides only minimal protection against this variant. And it's been confirmed by a range of laboratory studies. Penny Moore's group, based at the NICD in Johannesburg, and Alex Segal's group based here, they're just one floor above me, their labs have shown that when you look at convalescent serum from South Africans who were infected in the first wave, you get, I'm just waiting for James to mute himself. You get high levels of immune escape with the 501YV2 variant. So it looks like that protection from the first wave is not provided against this new variant. But as you might have heard yesterday, our scientists have found that if you do get infected with this variant, that it stimulates very good immunity against itself. And so you would be well protected against getting this virus. And because of its cross immunity with many of the other variants, it also does well in preventing the previous variants. So what do we know about vaccines? How do these variants impact vaccines? Well, if we look at the B117 variant, there's minimal impact. You see slight declines in neutralization, and there are different assays that are used. I won't bore you with those details. But if we look at the 501YV2 variant, and I've here listed the 8 vaccines for which we have clinical data of efficacy, but not all of them we've got evidence yet of how their immune neutralization is impacted. But we can see that for the 501YV2, we have differing levels at which the vaccine immunity that's in the blood of vaccinees, we look at how well can they kill this 501YV2 variant. And what we find is that the activity of their antibodies is lower. Now, what does that mean? It's not very clear. It's still under deliberation as to what these mean, but let's look at clinical efficacy. Does the variant impact how effective it is? And we only at this point have evidence from 3 vaccines. And on 2 of them, we only have evidence for mild disease. we only have evidence on mild and severe disease for one vaccine, and that's the Johnson & Johnson vaccine. Well, if we look for mild disease, we see for AstraZeneca that the vaccine is 70% efficacious in the UK and Brazil, but only 22% effective in South Africa in the midst of the 501YV2 variant. Similarly, the Novavax vaccine was 89% effective in the UK, but 49% effective against the 501YV2 in South Africa. Johnson & Johnson showed a much smaller decline from 72% in the US to 57% in South Africa. We don't yet have clinical data for the other vaccines, and it's unlikely we're going to be getting clinical data because it's not practical. These studies take so long to do that we're unlikely to see clinical evidence from them. So we're going to have to look at correlates of protection to understand whether these vaccines are being impacted. So one of the key things that we need to be thinking about is how to prepare for the next variants and vaccines. And there are many things we can do, including improving our surveillance for these variants. And I'm very pleased that the African CDC has taken this on. Actually, they initiated the network of laboratories in Africa to do phylogenetic surveillance even before we knew about the variants. And we know that we've got teams like Happy in Nigeria and Tulio in South Africa, and they've all come together to help us ensure in Africa that we are monitoring what our variants look like. And that will give us important information so that we understand what we're dealing with in the virus. And then, of course, there's certain things we need to do. We need to be creating repositories. We need to be developing the capacity to produce vaccines reactively. And now almost every company is making a new vaccine. We already heard Moderna's is already made and sent for clinical testing. These new vaccines are based on the 501YV2 variant, because they will then produce more robust responses against this variant. We know that Pfizer is making them, Johnson & Johnson, AstraZeneca, they're all making this next version of their vaccine to deal with the variants. And of course, importantly, that the variants are created because of viral replication. Every time that a virus makes a copy of itself, it increases the chance of creating a variant. Variants are created when the virus makes a copy of itself. So when the virus is making lots of copies of itself, the chances of a variant are much higher. So we want to suppress that. We want to keep viral replication. We want to keep the number of copies of the virus being made low as possible. And the way to do that is to suppress viral replication. In other words, reduce the number of people getting infected. And so we need to do that with all the tools that we have. Our prevention measures, such as social distancing and masks and so on. And importantly, the rollout of vaccines, because the vaccines are part and parcel of how we can impact on the transmission of this virus. Remembering that even though we are seeing diminished neutralization capacity of these vaccines, and even though we're seeing lower levels of effectiveness against mild disease, it seems that these vaccines still remain quite effective in preventing severe disease and hospitalization. And that's why it's really important that we continue our efforts to roll out vaccines and to achieve global equity in vaccine distribution. Thank you very much.
Thank you very, very much, Prof, for that very comprehensive briefing. And I'm sure you've answered a lot of questions that people had in their minds. Now, let me invite Dr. Merawi Arago of the Africa CDC, who's going to give us a short briefing on the Ebola epidemic in the DRC and in Guinea. Dr. Merawi, good morning.
Good morning. Thank you, Madam Minute. Good morning, colleagues. So I will just give you a brief overview of epidemiology of the current ongoing Ebola outbreak in 2 countries. So as of today, March 4th, a total of 28 cases, Ebola cases have been reported in 2 member states, in DR Congo and the Republic of Guinea. A total of 12 deaths have been reported, resulting in a case fatality ratio of 43%. This represents 64% increase in the number of cases reported this week compared to the last brief. In the DRC, since the last briefing, one new health zone, Butembo, has been reporting 3 new cases. Additionally, 2 new recoveries have been reported this week. Cumulatively, 11 confirmed with 4 deaths, with case fatality ratio of 36% have been reported in 4 health zones in North Kivu province, and 2 healthcare workers are among the cases. This represents a 38% increase in total number of cases reported this week compared to the last week. 8 of the confirmed cases are known contacts, 4 of whom had been vaccinated. To break down by health zones, Bena Health Zone reported 5 cases and 4 deaths. Butembo Health Zone, 3 cases with no deaths. And Katwa Health Zone, 2 cases and no deaths. Museneni Health Zone, 1 case and no deaths. In the Republic of Guinea, since the last brief, 8 new confirmed cases, 3 new deaths, and no new recoveries have been reported in the Rokore, Guinea. Cumulatively, 17 cases with 13 confirmed and 4 probable, with 8 deaths, with case fatality ratio of 47% have been reported in 2 regions. 5 healthcare workers are among the cases. This represents 89% increase in total number of cases reported this week compared to last week's brief. So by a breakdown by health zone, Conakry reported 1 case and no deaths, and this case has recovered. In the Rokore, 16 cases reported and 8 deaths and 1 recovered. 9 cases are currently hospitalized in the Rokore and receiving treatment. It should be noted that the case in Conakry traveled from Nizarokore and has since recovered. No active case currently reported in Conakry. Just to give you the update of overall response, and DR Congo, as of today, 634 contacts have been listed, and 86% of whom are currently being monitored. 856 persons have been vaccinated, and the DRC Ministry of Public Health is working with partners, including African CDC, in coordinating the overall response in North Kivu province. In Guinea, the general response is, as of today, 497 contacts have been registered, and all of whom are currently under follow-up. To date, 1,489 eligible individuals have been vaccinated, and the Ministry of Health also received Regeneron and MAB 114 for the treatment of EVD from WHO. The government has issued a protocol for travelers entering and leaving Guinea and to heighten surveillance and prevent cross-border spread of the virus. In this endeavor, Africa CDC is supported and working closely with both DR Congo and Guinea. And in the Republic of Congo, Africa CDC has conducted an initial need assessment to inform Africa CDC response plan and participated in the development of the Guinean National Response Plan for Ebola virus disease. On March 2nd, Africa CDC participated in an interministerial meeting with ministers of health from Cote d'Ivoire, Guinea-Bissau, Liberia, Senegal, and Sierra Leone to discuss strategies to prevent preparedness for and response to AVD outbreak in the region. Africa CDC leadership, led by the Deputy Director of Africa CDC, is visiting the 4 countries, Guinea, Sierra Leone, Liberia, and Cote d'Ivoire. Currently, they are in the field mission to assess and do dialogue and agree on with top leadership in the health sector in these countries on the key areas of support and strengthening response activities and preparedness activities in the affected areas, including neighboring countries. Africa CDC continues to prioritize event-based surveillance and animal monitoring, and we are doing media scanning to support early warning and response within the continent. And we are preparing a technical team deployment of experts into this for including affected countries and neighboring, high-risk neighboring countries, a team of experts. Thank you.
Thank you very, very much, Dr. John. Well, colleagues, we've had 3 very powerful presentations today. The first one from Dr. John, then Professor Salim Abdul Karim, and then lastly, Dr. Merawi Arago on the issues of COVID-19 and the Ebola outbreak. It's now time for our questions, so let's dive straight into that. Let's say good morning to Julia of Reuters, and this is Julia Paravicini. And Julia says, last week you said that 270 million doses would be allocated by this weekend, and that you would share the list of countries which received those doses. Can you share it, please? And then she has a second question. Are you negotiating a flat interest rate with Afreximbank for all the countries, or is it variable depending on the borrowing country? Is it 5%, 6%, or what? So she would like to have clarification on that. And those 2 questions are for Dr. John.
So thank you, Julia. Let me clarify what you are referring to. Last week, I indicated that a first set of vaccines that will be delivered, we are hoping this week, which is the 7 million that the MTN supported the continent to acquire to deliver to support healthcare workers vaccination. I think that much is very, very it's clear that we move forward. The 270 million doses, again, let me repeat what I said. I said the orders have in place. That is, the countries have put in their expression of interest for nearly all the vaccines that are the 270 million doses of vaccines. I further explained that what that means is that you've put in the request for vaccines. Then Afreximbank will use the request now to finalize the agreements with the manufacturers, and then that becomes an arrangement between the countries and the Afreximbank, and of course us that will provide the vaccines to the countries. So it wasn't a question of the vaccines will be delivered this week, the 270 million doses of vaccines. Very, very clearly not the case. So with respect to the interest rate, I would rather than give you information that is perhaps not accurate, you better, I think it will be safe to say that you engage with the Afreximbank so that they can be very, very explicit with what their financial arrangements are. We are in the AVAC together. AVAC is the African Vaccine Task Team, was set up by the former chair of the African Union. So we are in that together. Our role is to chart the public health direction of where we should be going as a continent, what vaccines we should be acquiring. The detailed negotiations of the financing and all of that is the work of the Afreximbank. So I strongly encourage anyone who has those questions to address them directly to the Afreximbank.
Thank you very much, John, for that answer. We have another question or 2 questions coming your way. And this one is from Alex Winning from Reuters in Johannesburg. And he says, good morning, Dr. John. What do countries have to do to confirm their participation in the African Union's vaccine plan after they have submitted their pre-orders on the AMSP website? And then he also goes on, do they have to open an account with Afreximbank? And lastly, are there any other steps that they have to take? So those are 3 questions from Alex Winning of Reuters in Johannesburg.
So very, very practical questions, Alex. There is various steps that they need to do. One is they open an account with the Afrexim Bank, which I think most countries have already expressed the interest for the 270 million doses have done. And at times it's facilitated by the Afrexim Bank folks to get them to open the account. And then secondly is that they now have to remain in negotiations with the Afrexim Bank for any clarification. I mean, our job is to inform the countries what the doses are on the platform, then link them up into the platform, and then they carry on the negotiation there. So I think that is what it is. We are now in the process of finalizing those contracts with the manufacturers there. So that is all the back end work that, again, takes some time to finalize, but that work is being done every day. And I mean it every day, every 8 p.m. There's a task force that comes together to review the progress and advise countries on where they are in the process in that whole process.
All right, thank you. We have colleagues who want to ask questions online. Let's start by saying good morning to Girum Chala. Girum, how are you? And please go on with your question.
Good morning, Madam Wayne. Can you hear me?
Yes, I can hear you very well. Please proceed.
Thank you so much. Dr. John, thank you so much. And Mr. Salim Abdul Karim. My questions are 2. The first one is in relation with partnership. As we understand, the African CDC has been using lots of partnership platforms to build up its capacity, not only to fight COVID-19, but others. In particular, I want us to discuss about the Chinese cooperation so far. Dr. John, how do you really evaluate the Chinese government providing for the continent in form of this financing of the construction of Africa CDC HQ?
So, Guillaume,
please zoom in, Dr. John, please.
Yes, I don't know if I want to be sure that I answer the correct question, because you dropped a little bit there, and I only heard towards the end where you talked about financing and the headquarters. If you don't mind repeating your question. I want to be sure that I'm answering the right question. Okay,
I can repeat the questions,
yeah,
but we can't see you, Doctor. You're off.
Yeah, they are working. They are the back end. They are trying to fix, I think, whatever the technical team is doing. You'll see me. You'll see me shortly.
Yeah. Now I can see you, and then we kindly can use this Zoom, because at the end of the day we're going to use this particular footage. So I'm only seeing 3 pictures. Kindly help us, because I don't want us to have a problem later when we share the video. Okay, I can repeat the final question, or I can repeat both very quickly. The first one is on partnership with the Chinese government when it comes to the fight against COVID-19, the provision of consignments and others. How do you really, in general terms, evaluate that, including the provision of vaccines for the continent? Number 2, Africa CDC HQ under construction at the moment. Very exciting for all of us. The Chinese government has provided finance and other things. How do you really also see that? What is China giving Africa in terms of Africa CDC HQ construction?
No, thank you, Guillaume. I think those are 2 very important questions. I will say that the whole premise for global health security, or Africa's health security, is based on the fact that we have to have trusted partnerships with, we can do our own things ourselves, but we know that the burden of what we have to deal with is so huge, and as such, partnerships is very important. I always remind myself of this saying, that there's nothing of value in mankind that is done solely by an individual or only a group of individuals. It has to be done with true partnership. So we welcome every support that China and other countries are providing. I think China has been supporting us, Africa CDC, extensively in the areas of diagnostics, in the areas of personal protective equipment, and even the foundations in China. The Jack Ma Foundation was one of the first to step in and gave us, supported us with about 3 different consignments of diagnostics and personal protective equipment. It was just yesterday that I was reflecting on that and sent an email to Jason, who is Jack Ma's chief of staff, on a really personal level, and said, that foundation met us at a point of need last year when we were very, very desperate. And I would forever remember that. That was very appropriate and very timely. So I think we value that. And all other countries have supported us since then. They probably heard England, the government of the UK, the European Union, the United States, and Canada, government of Canada, and Korea. The problem with listing names here is that you get into trouble because one, you forget somebody's name inadvertently, and then you get into trouble. But I just want to say that we truly appreciate the tremendous support, including from the foundations like the SCORE Foundation, the Bill and Melinda Gates Foundation, MasterCard Foundation, and many others that have really supported us. With respect to the HQ, you know that the groundbreaking occurred last December, and we continue to be very excited with the prospects of that, having our own headquarters, our own campus, and we look forward to the day that we invite you and have this press conference live from the new headquarters of the Africa CDC in Addis Ababa.
Thank you very much, John. We move to our WhatsApp chat, and we have a number of questions actually that have come in from Sarah Jerving, who is with DEVEX, and she has 3 questions. But I think what we'll do is that we'll give the first one to Professor Abdul Karim, and that is the question: what percentage of positive samples do you want countries to perform genomic sequencing on? So, Prof, I wonder if you have a comment on that before we move on to the next 2 questions from Sarah.
Sure, thank you very much, Win. So it's being discussed at the World Health Organization as to what is the minimum benchmark for phylogenetic surveillance. And I think at this point, there isn't a set number. In South Africa, the way we approach it is that we want samples from various facilities that have been designated as sentinel facilities. And from each of those, every month, a certain number of swabs get sent to Professor D'Oliveira's laboratory here. So essentially, we are doing in the region of around 300 to 400 phylogenetic assays every month. So that gives you some idea in relation to our epidemic, what the numbers are. I think it's not so much a threshold, it's important just that you do enough from the various facilities, get your geographical coverage, and ensure that you have at least 1 or 2 samples from each of them. I'll stop there.
All right, thank you very much, Prof.
I might want to supplement that as well, to say that what Professor Karim just indicated is exactly what it is. We have been saying on this platform that the sampling framework is very important. And you also have to be able to do that prospectively, because the question is, the fundamental question for vaccines is that variant dominating your pandemic? I mean, in HIV, and Prof. Salim would attest to this, we used to say, know your epidemic. In this situation, we are saying know your pandemic. And the only way you do that is that you have to sample that over time to really see how this variant is changing. If you use the South African experience, since October last year, and Prof. Karim can speak to this, they saw that the dynamics where this variant change over time and become really predominant. So at that point, you just have no option than to say that, I mean, your vaccine that cannot be used in that population. But if you're sampling, you do in country X, you take a few samples and you see that the variant is there. It doesn't tell you a lot. It doesn't tell you that this vaccine cannot be used in that context there. Just so that, I mean, just to complement what Professor Karim just said.
Thank you very much. Now, the next two questions from Sarah. She went on to ask, on average, what percentage are countries currently sequencing? Then her final question, what support is the Africa CDC providing to nations to increase their sequencing capacity? That's for you, Dr. John.
So that's a very good question, Kara. We've set ourselves a target of to produce 50,000 genomic sequencing by the end of the year, and do that using standardized protocols. I think that is one. Second is that we have further strengthened our networks of centers of excellence across a continent. And again, I don't want to risk naming names so that I don't get I don't omit certain centers. But let me just, for the sake of this conversation, say that you have centers like the African Genomics Center in Nigeria, headed by Professor Christian Happy, Professor Amadou Sall in Senegal, the Nenguchi Institute in Ghana. In South Africa, 2 sites are there. We can send you a slide that will show you the whole network of how we are set up to achieve this genomic sequencing. We are providing funding to sites that are ready to, that are already conducting this, including the site that Prof. Karim mentioned, we told you, in South Africa and others. We are providing sequencing materials to other sites, including the machines themselves there. So it's a very extensive network that we have set up, of course, working in partnership with the World Health Organization in Afro. I'm very pleased with that. That is one of the things that, as Prof. Karim said, we started the Pathogen Genomic Institute before COVID. So it looks like we were already well positioned to advance this area of work before the pandemic hit us. So we will keep you posted. Again, take-home message here is that we are projecting to sequence about 50,000 genomes by the end of the year. That we have a series of centers of excellence. And we are also, very importantly, have supported a large number of countries to move their samples, their specimens, to those centers of excellence for sequencing.
Thank you very, very much. We have a message from Professor Karim that he's had to leave because he had a standing 11 a.m. meeting. So thank you very much, Prof, for having joined us. We move on with Dr. John, and this next question comes from Lucia Blanco Gracia from the Spanish news agency. And Lucia says, you have said the allocation of the 270 million doses have been done already and the negotiations have started. Do you know when the shipments will start? Also, what about the other 400 million doses that the AU also secured? And then the last question, could you share an exhaustive list of countries that have already started the vaccination campaign? 3 questions from Lucia.
No, sure, absolutely, Chair. I think with respect to the last question, which I started off by saying that we do not have the list here today, but we promise you that next week we'll establish a comprehensive list of who has received what vaccines, and it may take a whole session by itself just to give you a list of which vaccines have been received in which country and how many doses and how many people are vaccinated. We are setting up a dashboard to track all of that. I think that is work in progress, but we'll be happy to share with you. When we announced those doses, the 270 million doses and the 400 doses, there is commitments that have been secured with companies, okay, the various vaccine manufacturers. And that means you have to go through the contracting process to sign legal documents and or the back end work that needs to go in there. As we said, if you saw that communique, you read the communique with President Ramaphosa, we are still hoping that by the June timeline that some of these doses will begin to come from that process. What is very important, and I really want to make this very clear, is that there are no COVAX vaccines or AVAC vaccines. What we should be looking at is what are we doing as a continent to get to 60%? Okay, that is extremely important for us, so that we also then look at the AVAC, which is the AVDA, the African Vaccine Alliance, to say if Nigeria is close to 2 million doses there, what are we doing to support them to roll that out? Remember, the target is at least 60% of our continent to be vaccinated. It becomes almost irrelevant as to who is giving that vaccine. We take vaccines from bilateral, we track them. We take vaccines from the AVAC platforms to complement what COVAX is providing. Remember, COVAX is promising to provide vaccines up to, I think, the level of 25%. But if we have to get to 60%, the continent needs to find vaccines. And if we do not get to at least 60% and above, I think it will become very challenging to manage this pandemic after 2022.
All right, and then our final question for today is coming from Megan Lawrence of Network 24 in South Africa. And Megan says, I have received word from the South African Department of Health that our AstraZeneca vaccines have been sold to the African Union. I spoke to the media liaison for the African Union in South Africa, who referred me to the HQ or the Africa CDC. Could Dr. John and Professor Karim comment on this? So Professor Karim has left, so that's a question for you, Dr. John.
No, absolutely. If you recall what Professor Karim just stated, that the vaccine didn't seem to work. So let me just give a little bit of history to this. I mean, South Africa had acquired 1.5 million doses of vaccines from the Serum Institute from India. And this is the same source of vaccines that any other vaccine that you are seeing across the continent is coming from the same source, the Serum Institute of India. So South Africa had negotiated a bilateral, obtained 1.5 million doses of vaccines. And just because of the data that you saw a few minutes ago from Professor Karim, showing that the AstraZeneca vaccine seemed to perform less well in that context, it then became an issue of how do we, as AVAC, that is the African Vaccine Acquisition Task Team, get those vaccines, because we are all in a rush to get vaccines to countries. And that is where it became a win-win situation for us, where us meaning the AU AVAC process. So we are in negotiations with the government of South Africa to get those vaccines and then distribute it in countries that do not yet have the issue of the variant. Again, all the vaccines that you heard this week are from the Serum Institute and the AstraZeneca vaccine. So that portion of vaccines from South Africa, we will get it as part of AVAC, and that will be supported by funding from the MTN as their donation, and we'll donate that to countries outside of the areas that the variant is more present.
All right, thank you so much. That brings us to the end of our questions for today. So it's time now for you to just quickly wrap up with the main points that you want the journalists away from today's briefing.
Let me start off with where Prof. Karim ended. Yeah, I think I really appreciate that he took time off his busy schedule to explain the variant. And the key message that I would like us to take away is that one is that we can, as we see the trends going down, it is a collective responsibility to continue to ensure that we do the right thing so that we maintain that curve downward. I mean, it means we are not very helpless, that if we continue to apply the public health measures, then the curve will continue to go down. And at some point, the second message is that public health measures alone are not enough. You see the curve go down, and if you look at that curve, the global curve carefully, you see that this at the very tail end, the curve seemed to begin to decide that it will go up there, and that is not a good sign in public health, that in the next coming weeks, you may actually see it come back. So we must be preparing for the potentially the third wave, and unless vaccines are here, and we use them appropriately, we'll continue to be in this wave movement where we come in with the next wave, and then we do certain things and lock down economies, which is very destructive there. So doing the right things, promoting the right public health messages is the only tools that we have in our hands. My second and last message is that it's all for all of us to provide the right communication messages to our communities that these vaccines are safe, that the variant issue is going to be minimized if we all go out there and get vaccinated once the vaccines are available. And that we know that the variant is predominant in Southern Africa, that other parts of the world, as they receive their vaccines, can, part of the continent, I mean to say, can go ahead and get vaccinated, such that there's no miscommunication with respect to whether, oh, these vaccines in South Africa are terribly not good, then there's no reason why Cameroon or Chad or Niger cannot use that because they heard that South Africa is not using it. The science behind why South Africa didn't use their vaccine. And I will rely on the media to also help clarify that as much as possible. Thank you, Wayne.
Thank you very much, John. Before we sign off, I just want to mention something that I heard on radio today, but I think it's something that we can tackle next week. The radio announcers were interacting with their listeners, and they were discussing the issue of the names of these variants. And they were saying that it really gets very confusing. So they were talking about B117, 501, YV2, PIB1128.1, and so on. So the general feeling seems to be that we need an easier way to refer to these variants so that people can understand them without necessarily attaching countries to them. So perhaps this is something that we can discuss next week, because really we've run out of time for today. Unless if you want to make
I agree with you fully. When let's devote a session next week or in the weeks ahead to discuss that. But there should be a group at the WHO that comes together to provide nomenclature. As you heard me say, we take an exception in attributing a variant to a country, because if we didn't do that with the virus, and it's also not helpful, because it begins to stigmatize people and also stigmatize countries there. The nomenclatures for now are very scientific. I mean, when you hear the N501Y, what does that mean? It means at position 501 in the nucleic acid chain, there's a change from asparagine amino acid to thyroxine amino acid. I'm not sure this even helps at all, because it's still a lot of jargon there, but just to tell you that is what it means by the N501Y change. It just changes in amino acids from one form of an amino acid. And if that change occurs, then it defines differently how the virus binds to your cell. If the initial amino acid there on that protein was asparagine, and it changes to thyroxine, it may completely change the way the virus sees your cells. That is all it is. But we can have a different discussion at a different time.
All right, I'm glad to hear that, because I think the ordinary people on the street would really appreciate knowing how to identify the different variants. But for now, let me thank you very much, Dr. John Nkengasong, the Director of the Africa Centers for Disease Control and Prevention and the Africa CDC, Professor Salim Abdul Karim, who is the Director of the Center for the AIDS Program of Research in South Africa, who is also co-chairing the South African Ministerial Advisory Committee on COVID-19, and is also a member of the African Union's African Task Force on Coronavirus. Let me thank lastly, but not least, Dr. Merawi Aregao, who is the incident manager for Ebola for the Africa CDC. Thank you all very much for being with us. Thank you for the team behind the scenes that made this possible. We will meet again next week on Thursday at the same time, and that is 11 a.m. East African time. Have a great week.
Thank you.
CDC Emergency Operations Center, Emily Rosenfeld, a public health lawyer with the US CDC, and Yusuf Kanute, a technical officer with the World Health Organization. Thank you all for joining the operations section webinar of our Incident Management System series. Translation services are available. Please click on the buttons at the bottom of the screen to access the translation services. You can also submit questions at the bottom of your screen in the Q&A box, and we'll be happy to address those questions during the question and answer portion following the presentation. Also, feel free to say hello to your colleagues and write comments in the chat box. If you've not already done so, we also encourage you to join the Public Health Emergency Operations Center Community of Practice on Discord for continuous engagement with experts and professional colleagues through the link on the flyer, and we will also put the link in the chat box throughout this presentation. After the session, you will receive a survey about your experiences with the course. Your feedback is incredibly important to us, and it helps us continue to improve future sessions. So we please encourage you to answer if you have thoughts. This series of webinars is the Incident Management System series. Today is the 5th of that series, focused on the operations function. Wessam will take us through the presentation, which will then be followed by a 20 minutes question and answer session. So please, again, feel free to write comments and experiences in the chat box and submit questions to the Q&A. Dr. Wessam has over 11 years of experience in public health emergency management, epidemiology, and practicing medicine. He has training in public health policy, epidemiology, and in 2016 was selected to support the establishment and operationalization of Africa CDC under the African Union Commission. He is currently serving as the lead of Africa CDC's Emergency Operations Center, and he's established a coalition in collaboration with others to push the agenda of PHEOCs in Africa and support member states to do so. He has also led Africa CDC missions in response to various outbreaks, such as Ebola in the DRC in 2019, Rift Valley fever in Kenya, and cholera in Zimbabwe in 2018. He is currently the Africa CDC incident manager for COVID-19 We are very happy to have his time today. So please, Dr. Wessam, over to you.
Thank you, Catherine, for this nice introduction. I'm really happy to be with you today to talk about the operation section and its role in the Public Health Emergency Operation Center, and also its role during a response to various outbreaks and emergencies. So let me share my screen. So today is part of the incident management system series, and our focus today will be on the operation section. In my presentation, we'll cover overview about the public health EUC and operation section. Then we'll go through the role of the operation section in different modes of operation like watch mode, alert mode, and response mode. And finally, we'll share and shed some of the experience of Africa CDC operation section and its role in response to COVID-19. First, as you know, Public Health Emergency Operation Center is the physical location where we manage information and resources to respond to various outbreaks and emergency. This is a location where we have our own staff, not only during the emergency time, but also during peacetime. We have watch staff all the time to follow what is going on. If this is national AUC, follow what is going on at national levels. Continental AUC will follow what is going on in the continent, and also what is going on beyond the continent that may have potential impact on the continent. Similar to COVID-19, when it started in China, then it starts spreading worldwide. So we're closely monitoring what is going on because it may have impact on the continent. So any public health event that may have impact on the continent, we are following through our watch staff in the Public Health Emergency Operation Center. So the public health operational structure mainly start with management part, where you have during peacetime, you have your AUC manager. Then under this management part, we have operation section. We have 4 main sections. The first one is operation section, second one planning section, and then logistics section, and finance and admin section. Our presentation today will focus on what is the role of operation section within the public health AUC and within incident management system. So quick overview about the operation section responsibility. First, it's managing the public health AUC activities. Whatever activities going on within the public health AUC, how to manage the AUC, this is the responsibility of the operation section. Then when we activate to respond to certain incident, how to use the resources to respond directly to an event, this is the responsibility of the operation section. And based on the level of the public health AUC, the operation rule may vary. So if you're at national level public health AUC, the operation function during this time in response to emergency, mainly for coordination, mainly for providing technical guidance for all the response operation, and also providing plan for how the response looks like. This is in collaboration with planning section. However, if you had at site level response at subnational level, so mainly the operation will be focusing on technical area. This is direct and tactic response. Sometimes you may have activities, operation section will be responsible for implementing it related to vaccination, related to contact tracing, triaging, treating sick or injured people, conducting decontamination. So this is various responsibility for the operation section when it comes to response to various outbreaks and emergencies. As you know, we have 3 modes for operation for our public health emergency operation center. The first mode is watch mode, second one is alert mode, and third mode is response mode. So during watch mode is all the time. During peacetime, your operation section and your public health AUC is in a watch mode to follow what is going on in your country, what is going on worldwide and may have impact on your country, what is going on in your region. So during this time, the Public Health Emergency Operations Center, we have the Public Health AUC Manager, we have the watch staff. Ideally, it should be 24/7, 365 days per year, watching what is going on. Then you have also core AUC staff that cover not only the operational part, but also cover the planning, cover logistics, and cover finance and admin part. And during watch mode, it's important also the role of event-based surveillance to early pick up what is going on in your country related to various public health events. And during watch mode, we produce different spot trip and sit trip for sharing information. In my future slides, we'll touch base on and take more details about each one of these different functions. Then in alert mode, so as we mentioned, watch mode is all the time, even if we move to alert mode because we picked some signals related to public health event, and we decided to move to alert mode and closely following what is going on related to this signal. So watch mode staff there to follow and closely monitoring what is going on. We need also subject matter expert to be analysis for the situation. Also for the surveillance system, it's important during this time to be enhanced and closely monitoring the situation. And we may need to conduct preliminary assessment as well. Team from different experts are convened to do assessment for the situation. Then notification also may be generated. Incidental action plan could be prepared during this time. Preparation for deployment, maybe rapid response team. You need to deploy rapid response team to verify the information, see how the situation looks like on the ground. Then if we decided to move from alert mode, now we met certain threshold set within the AUC that now this is the time for response and we need to move to response mode. So we are alerting our staff that we are moving to response mode through different kind of notification. We'll speak later about these notifications. We'll have our INSA manager to be appointed. We'll have IMS structure will be in place. We'll have liaison officer to communicate with different partners. Our public health AUC activated. We have incidental action plan developed and finalized with a specific operational period. Also start deploying resources, situational awareness conducted, and we have response specific reporting. This is overview about different modes of operation that the public health AUC may go through during from peacetime, during alert mode, during the response mode based on the emergency. So let's go and make a deep dive and see what is the role of operation during watch mode. Watch mode, this is the peacetime. We're tracking what is going on in our country. We're tracking what is going on in our continent. So during this peacetime, we have a dedicated staff following what is going on. And they're mainly monitoring the situation. They are doing three main things. The first one, they are collecting information from different resources. They are getting report from our event-based surveillance team. They are getting report from our indicator-based surveillance team. They are collecting information from media. Sometimes if you have hotline, they are receiving some of the calls from hotline. So they collecting different and gather different kind of information. So the first thing, they are collecting the information. Second, they start triaging this information. So what do we mean by triage? This is important for our public health AUC. This meet certain criteria that need our public health AUC to be alerted, to inform our leadership regarding it, to start preparing for response to this kind of emergency. So this kind of triage. And during this time, we're using what is called CIR, Critical Information Requirement. We have two kinds of information in the public health AUC, and this is important to our watch staff. The first one is called EEIs, Essential Element for Information. This is the information that our watch staff collecting on a regular basis. For example, a number of cases regarding certain disease, or number of deaths regarding certain disease, or number of bed occupancy rate, for example, in the hospital, or ICU occupancy rate in certain hospital. So they collect this information routinely. And this kind of essential element of information, it's important for decision making. Then we have subset of these essential element of information called CIR, critical information requirements. So once we hit the CIR, so this will trigger action. For example, we are collecting information about a number of cases of meningitis, for example. So the CIR will be if this number exceeding certain limits, and we specify this certain limit to our watch staff. If the number reported is exceeding this limit, this has become a CIR. So they need to start producing certain kind of report, like spot trip or set trip. We'll speak later about this kind of reporting. So you are another example for CIR, if we have like new or emerging disease, like COVID-19. So this is kind of CIR. If one of your staff deployed to the field and get injured or got the disease, so this is maybe one of the CIR. So you have list of CIR, make this list available for our watch staff. Once while they are collecting the information and they meet any of these CIR, so they need to trigger action. They need to call the leadership in the AUC, maybe sometimes the leadership in your organization to be informed through the reporting. And for the report, we have two kinds of reports, also drafted by our watch staff. The first one is spot trip and second one is set trip. So what is the difference between a spot trip and set trip? For the spot trip part, this is the early information that we're collecting. Most of the time, this is still unverified information, but we need to alert our AUC manager or our leadership regarding this initial information that we collected. Then once we have detailed information and verified information, this verified information with more details, and sometimes we need subject matter expert input in it. So this become like set trip. You have detailed information and this information is verified. So our watch staff, they collect information, then they triage this information based on the CIRs. Then whenever they meet the CIR, so they start reporting this information. So also during the watch mode, the operation section is responsible for ensuring that our public health AUC supplies are in place, available to ensure the operational of the public health AUC. Also, they coordinate or lead briefing as required. If there is briefing need to be done to brief the leadership about certain situations, so watch staff and operation section is coordinating this kind of briefing. So in summary, our watch desk, which is part of the operation section, is responsible for collect information and collection to cover 5 W's: who, what, why, when this event occurred and where it's occurred. Then determine if this information, if this meet the critical information requirement, so we need to do certain action, we need to report this event to the leadership. Then determine the kind of report that should be established based on this incident, if it is spot trip or set trip, and then they start disseminating this kind of report that produced. So this is the role of operation section during the watch mode. So if this meet the CIR and now we decided to move to alert mode and we need to have close monitoring for the situation, what will be the role of the operation section during this time? So in an alert mode, we have list of subject matter expert. This list should be available within the AUC and available for the watch staff. And this subject matter expert can be classified by disease. We have subject matter expert related to meningitis. We have subject matter expert related to yellow fever, subject matter expert related to meteorological event. So we have list of subject matter expert. So, and this list is identified and available for our watch staff and available for our operation section to communicate with to get more input related to certain event. During watch mode, during alert mode, sorry, also our surveillance system should enhance it. If we track certain event like COVID-19, when it start to having few cases of unknown virus spreading in China, then it started spreading. So during this time, we need to enhance our surveillance system to collect as much information as we can to get more details about what is going on. Then notification are generated. So for the notification port, we have different kind of notification. We have 4 notification usually we are using within the public health UC. The first one is alert notification. Second one is warning notification. Third one is activation notification. Third and fourth one is execution notification. For alert, we picked signal related to certain event, and this is verified. And now we need to move to warn our staff, our leadership about this event. So we are sending alert notification. We are sending this alert notification during the watch mode. We inform our leadership, our staff who are currently closely following certain event. It may be of concern, it may affect our country, our continent. So this is alert notification. Then when the level of concern increase, we may issue also warning notification. And this warning notification can be issued during watch mode or during alert mode. So if we are in watch mode, or this event now is increasing in the concern, so we can go directly and issue warning notification. Or during alert mode, we can issue this warning notification. However, if this incident meets certain requirement and certain threshold identified within the AUC, and we decided now to move from alert mode to response mode to activate our Public Health Emergency Operations Center. So during this time, we are sending activation notification. And these activation notifications state mainly who is the incident manager and what is the initial incident management structure, how it looks like, and also the time for activation our AUC and the date for activation for our AUC. Then once we activate our Emergency Operations Center, there is another notification called execution notification, inform all staff and different stakeholders that our AUC is currently activated. This is the incident manager. This is our objective for the response. So this is execution notification. So also during this alert mode, we can conduct also preliminary assessment team can convene and to assess the situation during this alert mode. Also, we can start drafting the incidental action plan. As you know, initially, you should have like multi-hazard preparedness and response plan. Then you have also hazard specific plan. Once you have certain event happen in your country, you start adopting this hazard specific plan and multi-hazard preparedness and response plan to the current situation and develop incidental action plan. This is operational plan with a specific duration to inform different operation section and different body involved in the response, what kind of activities that you will be implementing to respond to this outbreak within this specific duration. It could be week, it could be days, it could be 1 month, usually it's short period. Then we update this incidental action plan as we go. Then also during the alert mode, we can deploy our rapid response team to do some sort of initial assessment, to collect more information about the event that is happening. As I mentioned, watch team is continuous all the time. Yes, our public health UC can be alerted to certain event, can be alerted to COVID, but we have our watch staff continue monitoring other events, similar to they may be like Ebola currently going on in Guinea and DRC. So we have our watch mode all the time, continue following other events that may occur while you are responding or you are orienting related to certain events. So this is the role of operation section during the alert mode. Then another important role is the role of the operation section during the response mode. What will be the role? And this is one of the most important part. The operation section, as we said, they are the one responsible for implementation of the emergency response. Whatever plan that we have, the people that turn this plan to reality, the people that try to contain this outbreak or emergency. So this is the operation section. And they are responsible for assigning the right task to the right people at the right time. This is the responsibility of the operation section. In the operation section, during the response time, they are putting the strategies and the plan in collaboration with incident planning section in our incident management structure. And they are the one who decide how to implement this plan, how to develop strategies and tactic to move this plan from the paper to the realities. Also, they are informing and coordinating our daily response activities and ensure our emergency preparedness and response plan, hazard specific plan, and incidental action plan, all of them become operational and executable. So this is the responsibility of our operation section. Also during the response time, operation section, they are monitoring and tracking the requests for information that we are getting. For example, in our Africa CDC Emergency Operation Center, we received during COVID-19 response, we received a lot of requests for information from different countries, asking us about guidance for example, school opening, or guidance related to IPC measure that should be in place on the work setting to ensure the safety of the work setting during COVID-19 period. So the operation sections tracking all these kind of requests for information that come to public health UC from different sectors. And also they are tracking the requests for assistance that you are receiving. So at continental level, we're receiving requests for assistance from member state. So country X need support in IPC equipment. Early at the beginning of COVID-19, because there is limitation on the availability of test kits, we're receiving requests for support to having test kits for COVID-19 available to country X or country Y. So at your national level, you may receive from your state that, okay, we need this kind of request for support. We need additional surveillance colleagues. We need a physician also to support. So this kind of request, it may be human resources. It may be resources like IPC equipment, like drugs, vaccines, and so on. So for during the response mode, your public health UC may activated either partially or fully activated. And we have grades for activation. It can be partial or fully. Some countries are classifying the response, the activation to 3 levels, level 1, level 2, level lower level, middle level, higher level. So on each level of this activation will be corresponding to what kind of resources that will be available during this level of activation. If you at the lowest level of activation, so the resources that will be available will be small resources, and also lowest level. If this is like big event, including multiple regions, including many governorates, so you can activate you at second level or third level. So based on the event, you decide the level of activation, and this should be set clearly within the public health. You see in the SOPs for activation. What kind of levels of activation you have? You have 2 levels or 3 levels, and for each level, what kind of resources that will be allocated to deal with each of these levels. So for the response mode, our operation section is responsible to monitor, track, and distribution of the following things. First, daily staff rhythm. What kind of activities we'll keep doing on a daily basis in the AUC? What kind, for example, meeting that will be happenings, briefing that will be occurring, if any trainings will be needed. So daily staff rhythm. Also event-specific CIR. Initially, we covered TIR. For example, for COVID-19 or for Ebola, we now activated our emergency operation center to tackle Ebola, to deal with Ebola. But Ebola, for example, in DRC in 2019, mainly was in scheduling different meeting, calendar invitation, having the space required for this kind of meeting. This is the responsibility of the operation section during the response part. Mission assignment, who will be assigned to do what kind of task will be assigned to each person to complete the incidental action plan, which will be reflecting on our emergency response plan to this event. Also managing the request for information, request for assistance, how to move the incidental action plan from the paper to reality. Also to update the information about our response in the response thread in collaboration with the planning section. So this is how I miss. If you remember in my first slide, we give like short kind of IMS, which include the management part. You have operation section, planning section, logistics section, and finance section. During the activation time, the benefit of IMS structure is scalable and it's modular. So based on the situation, you can increase the scale and also increase the number of people involved, increase different groups and unit within your IMS. So for example, in the operation, let's focus on the operation part. During the response, you may have team focus on surveillance part, group focus on surveillance, you have laboratory group, you have port of entry group, you have case management group, IPC group, risk communication, and research. You may not have all of them, you may have part of them, so this is depend on the situation and the response to various outbreaks. So the operation, as you mentioned, one of the important roles is the task management, and this task assigned to each person by operation section. This is sole responsibility for the operation section to identify the task and assign tasks to different persons. And this task may have tasks related to information requirements, some tasks related to requests for assistance that we're receiving from the member state, or requests we're receiving from our leadership, or different tasks related to the implementation of the incidental action plan. What is not task? So task should be specific. And what is not task? Any sustained support provided by public health AUC. For example, daily cleaning for the public health AUC. We shouldn't include this as task in our task tracker. Maybe regularly checking the status of the equipment in the public health AUC. So whatever daily activities were conducted, so this shouldn't be included in our task tracker. So for these kind of activities, we may have it in a routine checklist. So we have routine checklist for daily staffism, we have routine checklists for the set reps that we're producing, routine checklists for maintaining the equipment, for cleaning the public health AUC, and so on. For who issue and track different tasks, as you mentioned, this is done by operation section, tracking tasks. Will prioritize this task, then identify who will be assigned to do whatever task needed, then develop task description, including only permanent information related to this task, assign task to the person, identify the normal duties. As you know, during the response time, before the response, we have only the core team work in the public health AUC. During the response, we have surge staff who are calling people from different division or different unit within your ministry, within Africa CDC. They come and support us in the response. So once we deactivating, the operation section will be managing to return people to their normal duties, and also reporting and the staff return to the pre-activation status. So the operations section will be responsible for releasing and returning resources. These resources may be human resources or equipment to the watch mode, to the mode before the activation. So at the final, for the operations section, is the one conducting the final incident closeout of the public health operation, and this is include turnover of the documentation and incident debriefing, and also distribute the activation notification. Now we are ending our response. Then schedule and track the deactivation action. This is in summary the role of the operation section during the deactivation part. And finally, let me go through experience from Africa CDC, which is related to the role of operation section in COVID-19 response. We can go quickly on this part. So this is how the initial structure for incident management structure for Africa CDC early at the beginning of COVID-19. We have incident manager, then we have the management part, include the zone officer, safety and security officer, and public information officer responsible for the communication part. Then we have operations section. During this time, we have group focus on surveillance part, we have group focus on laboratory part, preparedness and countermeasure, and under preparedness and countermeasure, we have the team focus on IPC part and team focus on case management part. Then we have RRT group as well. So this is the main groups under operation initially at the beginning of this COVID-19. But we decided that our role in Africa CDC should be how to coordinate and communicate between member states and collect the effort of the continent together. This is why early at the beginning of this pandemic, almost 1 week after having the first case reported in the continent in Egypt on 15th of February. On 22nd of February, we called for emergency ministerial meeting at African Union to inviting health ministers of Africa that we need to move forward together. And during this meeting, so the health minister adopted Africa Joint Continental Strategy for COVID-19 and also endorsed Africa Task Force for COVID-19 as a continental mechanism to coordinate, collaborate, and communicate between member states to respond to this COVID-19. And this has become the structure of AFCOR Task Force. At the top, we have African Union Bureau, which is composed of 5 heads of state. Each one represent each one of the 5 regions of Africa. This is in addition to African Union chairperson and also African Union chair, in addition to Africa CDC director as well. Then under African Union Bureau, we have 3 ministerial committees. One focus on health, this is include health ministers, another one for transport and logistics, and third one for finance. The 3 ministerial committees. Then we have steering committee for AFCOR Task Force, which is co-chaired by Africa CDC director and Dr. Muti, the Director General for AFRO, Regional Director for AFRO. Then under the steering committee, we have 7 technical working groups. And this technical working group are giving technical guidance for the incident management structure within Africa CDC. So we have technical working group focused on surveillance, another on clinical care management, infection prevention control, supply chain stockpiling, laboratory diagnosis, risk communication, research standard. And this is working closely with the regional health coordinating committees for Eastern, Central, West, Southern, and North Africa as well. So the information coming and the guidance coming from this AFCOR task force is guiding our response and guiding our operation within Africa CDC. And the leads for these different technical working groups, it's called by experts from Africa CDC, also experts from member states, experts from WHO, and also subject matter experts from various countries, and also some partners included in these different technical working groups. So we're informing them about what we are noticing. They give us technical advice how to move forward. And within Africa CDC, every now and then we're updating also our response based on the information that we are gathering on a daily basis. We have our meeting for public health. You see, we have 3 times per week, organized by operation section. This is where all the stuff included in the response are meeting Monday, Wednesday, and Friday to share the epidemiological update about what is going on in the situation, and also to get brief about the knowledge management update. This is a new disease. Every now and then we have lots of publication related to this event. So we're getting update from our knowledge management group. Then we track all the activities that assigned to different section, like activities assigned to surveillance, laboratory preparedness, or rapid response team in the field. So we track the progress and the implementation of these activities during this 3 times weekly meetings. And also the importance of this part, as I mentioned about the incident management system, it's scalable and modular. So initially we started with surveillance, laboratory, preparedness and countermeasure, and rapid response team. Then with the time, or during, for example, in June, so the talks about the vaccination, there are clinical trials starting. So during this time, it was important to add also vaccination group to focus on the vaccine part. Also, during April, we launched an initiative focused on community health workers. So we added community health workers team to be working under surveillance group. So this is how we start improving or advancing our incident management structure to meet what is going on in the continent and worldwide related to COVID-19. Also, with the information that we are collecting through our surveillance systems, through our knowledge management, the information also that we are getting from our operation team, this is inform the leadership about what kind of challenges that we are facing in the continent related to this response. So this is when we start every now and then launching certain initiative to focus on a specific part of the response. So as I mentioned, we have Africa Joint Continental Strategy. This is overall strategy to guide our response, and we have Africa Task Force for COVID-19. Then in April, we noticed that number of tests that is still available in the continent and rolled out in the continent, still very few. So this is when we launched an initiative called PACT Initiative, Partnership for Accelerating COVID-19 Testing. It's mainly to mobilize more tests for the continent, advise the countries that we need more testing to be conducted, because most of the countries during this time, they have below than the recommended ratio for WHO, 10 to 30 tests per case ratio. And we set a target during this time. We need to reach 1 million tests within 4 weeks. In the coming 4 months, we need to hit like 10 million tests in the continent. Currently, we reach around 34 million tests conducted in the continent. Also, we notice that there is a challenges facing the member states in having infection prevention control supplies, test kits available. So this is when also we launched Africa Medical Supply platform to give access to the member states with the high-level producer and manufacturer worldwide, so they can go and each country have account on this Africa Medical Supply platform. They can go directly and start placing orders related to IPC supplies, some of medical equipment, and also test kits. With growing talk for vaccine and clinical trials and vaccine availability. So this is when also we start adding vaccine group to focus on this part, and we launched Africa strategy for COVID-19 vaccine and vaccine acquisition, and which is have 3 components. The first one, mapping the clinical trial going on the continent. Second part, focus on the vaccine acquisition, and third part related to the regulation and uptake and delivery for the vaccine. Also, when we notice that COVID-19 is not only health-related problem, but it has a huge impact on economies, has huge impact on our livelihoods, and with this kind of travel restriction. So we launched Africa Against COVID-19 campaign, Saving Life, Economies, and Livelihood, to focus on how to regain again the travel. We have travel restriction, border closure at the beginning of this COVID-19. We launched recently trusted travel platform to ease the movement between the member states, also issue guidance related to school opening and how can our intervention make less harm on the economy as well, and taking in consideration the economic aspect as well. So this is in summary the activities that we conducted so far in Africa CDC in terms of different kind of trainings to support member state for laboratory, surveillance, IPC risk communication, case management, public health AUC. In addition, also to lab supplies that we provided to member state and IPC supplies, more than 7.5 million tests provided to the member state, more than 12 million masks provided to the countries, in addition to various equipment supporting genome sequencing currently in 20 countries. We are targeting to increase genome sequencing. Currently, we have around 8,000 genome sequence done in the continent. We are targeting by end of 21 to reach to 50,000 genome sequencing to be conducted in the continent. And this is also summary dashboard for our deployment to support member state, either rapid responders to support various countries. We have around 165 responders currently deployed to support different member states. This is in addition to more than 16,000 community healthcare workers support contact tracing, raising awareness, and also we're planning to use them for vaccination campaigns as well. So this is in brief how the operation section looks like. What is the role of the operation during watch mode, during alert mode, during the response mode, and experience from Africa CDC. I'm happy to receive your questions.
Dr. Weslam, thank you so much. I think having your insight and the very practical experiences helps bring together all of the previous incident management system series that we've had. I know from my point, it helped bring together a lot of those concepts, show the very practical nature of how they're carried out, especially thinking of things like how the watch mode is continuous and then you build upon as you go into alert and response. Extremely helpful. And I also think that's reflected, that level of really practical, helpful information is also reflected in the amount of questions that we have received for you and for the panelists. And so I want to move into the question and answer portion. Emily and Yusuf, I know that you have been watching the questions.
Those activities take place. So wondering if you could address kind of both of those together, however you see fit. So thank you.
Okay, thank you, Emily. This is one of the important questions because as it was mentioned in the comments, we have limited human resources available. So how can we best use of the available human resources to respond to the virus outbreak and emergency? So this is why we mentioned during the watch mode. So what you need, dedicated people to track the event, track what is going on. And this is based on the resources that you have. If you can go for 24/7, this is the best. If you can have like 1 or 2 people per shift to track the event, this will be very good. This is in addition to the core stuff for the public health AUC itself, which include the AUC manager, operation section chief, and the planning. This is the minimal that you need to have. If you have also the logistics section chief, in addition to finance and admin, dedicated person, this is good during the watch mode. Then when you start to moving to alert mode, and before moving to alert mode, it's important to have training in place to train surge stuff. And this is done during the peacetime. Most of the people think that the role of the public health AUC is only coming during the response part. But the most important part for the public health AUC during the peacetime, this is when we are preparing for the response. When you are training the surge stuff, I remember my talk with Africa CDC director. Each time we're requesting for more staff to join our emergency preparedness and response division in Africa CDC. He usually tell me, Wissam, don't worry, during the emergency, all of Africa CDC staff will be working under you. So don't worry about the stuff. But the important rule during the peacetime that you need to orient those staff that not working under you directly during the peacetime. You need to orient them about the public health AUC, the role of the public health AUC, different function within the public health AUC. So once you are activate your AUC or start moving to alert level or response level, so those people are aware of different function, different SOPs that we'll be using, different plan that we have in the AUC. This is will fast track the engagement of the people in the response part. So we encourage all our member states and our colleagues. Lots of investment need to be done during the peacetime in order to get benefit of the public health you see during the response part. Over to you.
Wonderful. And Yusuf, I don't know if you have additional comments, or Emily, thoughts or any follow-up questions?
That a bit further and maybe give some, I guess, additional lessons learned or an example of, really how you work, at Africa CDC and what you've learned potentially even, from your other colleagues in terms of or that you're, really making those plans, but also testing and, figuring out what you need to do so that in the event of an emergency, you're not scrambling to figure all of that out at that time. So wondering if you could comment a bit further on that or elaborate.
Yeah, actually, this is a good thing, especially with COVID-19. This is a new emerging disease, new disease. Early at the beginning of this COVID-19, no one knows how can we control this. What is the best tools that we can use to get better result about controlling the COVID-19. So early we start developing our strategy, and it's important while you are moving to implement this strategy to track what is going on and to start drawing lessons from this implementation, what worked, what doesn't work, and how to improve your work. So as I mentioned, while we are implementing these strategies, few cases reported in the continent, we have challenges with rolling out the testing in the continent. This is why it's important for Africa CDC to focus on this part. And when you are, yes, we launched the strategy early at the beginning, but we found that every time we are launching certain initiative, it grabbed the attention of the media, it grabbed the attention of different donors related to the issues that we're focusing.
If your technology is working, I'll turn it to you for any thoughts or questions that you might have picked up.
And also, okay, tell Yusuf come back. while we are responding, and this is also touch again the question that Emily raised. Some of the document that we have within our public health was not complete. Like some of the SOPs was not complete, CR was not complete. So we start making use of the additional human resources that we got in the public health UC, and they have now more people focusing on the work in the public health UC to start completing the missing document that we didn't have before the COVID-19. Also with different tasks available, with different tools that we need within the public health UC. So we start also updating our TORs to meet the requirement that we need during this time. So it's important to make use of the emergency once he assigned the task to a certain, also will be having access on this to update the status of the task. It is completed or in progress. And this will be reflecting in the overall performance. And also we're planning to link these tasks with the financial aspect. So all this kind of circle, starting from tasks, the financial allocation, the financial reports, to be linked together in one of the software application. Social media and the information that we are collecting, especially with this COVID-19, lots of misinformation and infodemic part, it was a big challenge. Then that's why our communication team, also they have what is called like rumor tracking, using certain software within Africa CDC to track what kind of rumors that going on every week in the continent. And they are inform us in our public health UC meeting, or during this time we have misinformation about, for example, the vaccine. This is why you'll find Africa CDC launching campaign about the vaccine part. And we started also to have like vaccine acceptance survey to know what is the real situation in the countries, to collect information about the vaccine acceptance when the vaccine become available in the continent, how the people are accepting this vaccine. So it's very, very important to continue collect this information and use whatever available software to improve our capacities.
Very interesting. That social media is not only a way to give information to the public, but also needs to be monitored. Very interesting. Emily, Yusuf, comments, thoughts, or other questions that you found that you'd like to pose?
Great, thank you. And Yusuf, if your technology is allowing, please do feel free to step in. So I think I have two questions, and I may combine them a little bit. One, I think, is on the use of terminology and sort of recommendations. I think, there was some discussion about, refer to PHEOC activation at the point where the PHEOC moves into response mode, while other times it seems that documents refer to the modes themselves, watch, alert, response at different levels of activation. So I was wondering if
you're using. So this is what we try to do to support this part, to having common terminology within the continent, and lots of effort is still needed in this regard. And this is why we are continue through this public health UC webinar and joint activity support.
I think we have time for about one or two more questions. I'd like to all of our participants to put experiences, thoughts in the chat or in the Q&A. We'll certainly answer anything we didn't get to through Discord, through the engagement on Discord. For the last question, I want to take a moment to talk through deactivation, because I think it does, given the current emergency, we spend a little bit less time thinking and talking about it, but difficult task, especially sitting where we are now, but it's an important one, right? To be able to think through those layers and of how you return to normal, the decisions that need to be made, how to return resources like you talked about. Could you give us any, maybe of the challenges you faced or the experiences you've learned that people can start thinking through, that they need to think about from your past experiences or your current?
Yeah, thank you. When we start speaking about deactivation, we need also to mention another expression that we use. Usually come with the deactivation, the expression for de-escalation. So even before you have criteria for deactivating your public health UC and in your operation, you need also to start thinking about de-escalation. We mentioned we are activating our public health UC. We may have partial activation or full activation. We may have lots of resources in this full activation. So you need for each public health UC, and this is vary according to the event that you are tackling, to have also criteria for de-escalation. What criteria that when you meet this criteria may be related to the number of cases that will be occurring, related to the geographical scope of the outbreak that is happening, the resources that will be available during this time. So we decide to de-escalate your operation. Then you reach for the second part, is deactivation part. Also, we need to have for the public health UC, and this is one of the important SOPs that need to be available in your public health UC. What criteria that you will have in place to deactivate your AUC and return back to the normal time. For example, during the Ebola part, you start de-escalation. When you find number of cases start going down, only few cases available and maybe few geographical location. During Ebola in 2019, we have spread in different localities for North Kivu, Butembo, Beni, Katwa, and all these areas start going down. And geographical scope also start going down. So we and also WHO start deciding to decrease the number of staff that will be available to tackle this event. Then when you stop reporting cases, what you need during this time to enhance your surveillance after 2 incubation period, you need to enhance your surveillance. So maybe you need more staff focus on surveillance point when this outbreak is declared over, after having this 90 days strengthen the surveillance after the first 2 incubation period without any cases reported. So set of standards should be in place, having the criteria for your de-escalation and deactivation. Once you start meeting these criteria, start de-escalating, then deactivating, and also you need to have continuous engagement with the leadership, because sometimes with kind of political pressure, it may also delay the decision that you take for deactivating your public health UC. So all these consideration, all these issues need to be taken in consideration before taking such decisions. Over to you.
Thank you very much. Very helpful. Ah, Yusuf. Hello, we can hear you.
Apologies, it's like I have some internet issues here, but I'm really glad you guys could go through the questions.
To deploy team to the country, this should be based on requests from the country. But when you are managing incidents and you are the national public health UC, so you will not face such a problem. So whenever the information that you are collecting, you have your event-based surveillance, and for event-based surveillance, mainly you are depending on the information that you are collecting through the media. If you find this information is not sufficient for you, and you have now this unverified information, you need further details about the situation. You may not have the technical expertise and the capacity available at subnational level to do thorough investigation and assess the situation on the ground. So at this point of time, you may send national team to do assessment. If the people at the subnational level, they have this kind of capacity, so we encourage to use them and to give them the power and the confidence to do this kind of preliminary assessment. If they need additional support from a national level, and support them. Over to you.
Excellent. Thank you all for this round of questions. I think we've seen a record number of questions come into the Q&A box today. We are a bit over time, and I want to be conscious of everyone's time today. So I'd like to take a moment first to just ask Emily, Yusuf, Wessam, if you have additional thoughts, final thoughts for the participants. Over to you.
Thank you for your participation, and thank you to Wessam for a wonderful presentation. Thank you to all of you for being here.
Catherine, just to thank you for, do you hear me?
We do, yes, please continue.
Yeah, to thank you for the great job you did in chairing the session. Thanks to Wessam, really very informative his presentation. Thanks to Emily and
Catherine, Emily, Yusuf. Thank you, everyone.
Thank you.
Bye.
Thank you all. Bye. Thank you all. Bye. Have a good day.
You too. Thank you, Wami. Thank you, Silas.